Okay, let's talk about something that's way too overlooked in patient care, but is absolutely critical: sleep. We're going to go way beyond just getting some rest and reframe sleep for what it really is: a vital sign that can literally be a matter of life and death. Mastering this is a game changer for your nursing practice.
So you might be thinking, is sleep really that big of a deal? Isn't it just about making the patient comfortable? The answer is a hard no. In fact, that's a pretty dangerous way to think about it. In the hospital, not understanding the science of sleep can lead to some really severe and sometimes, fatal outcomes. And this is exactly why you have to start thinking of sleep as a vital sign. When it's messed with, it's not a comfort problem, it's a direct threat to your patient. We see things like ICU delirium pop up super fast, healing slows way down, the immune system just tanks, and in the most serious cases, it can lead to a total airway collapse or even be a key factor in SIDS.
To really protect our patients, we've got to get the basics down, and that means knowing the two fundamental types of sleep. A really easy way to think about it is like two different specialist teams that work the night shift. You've got the body's repair crew, and then you've got the brain's filing system. And here's the kicker: your patient absolutely cannot heal without both of them showing up for work.
First up is the body's healer, NREM stage N3. You might also hear it called slow wave sleep. This is the deepest sleep you can get. Now, the magic ingredient here is the release of human growth hormone. This is when the body does all its heavy lifting. We're talking repairing cells, building proteins, and renewing tissues. If your patient doesn't get this, their physical healing is going to be in serious trouble.
Then we have REM sleep, which is the brain's healer. Now, the body is pretty still, but the brain, it is buzzing with activity. Blood flow is cranked up. This is absolutely essential for locking in memories, processing stress, and just rebooting cognitive function. It's why a patient who's deprived of REM sleep can get confused, super irritable, and emotionally unstable, like really fast.
So let's just break it down side by side. NREM sleep, which makes up most of the night, is all about physical repair. REM sleep is a shorter but intensely important period for, mental housekeeping. For a patient to actually get better, they need a healthy dose of both, every single night, no exceptions.
Okay, now let's apply this knowledge to a huge airway emergency: obstructive sleep apnea, or OSA. I want you to really visualize this with me. Think of it like a little movie playing out step by step, showing what's actually happening inside the airway.
All right, here's how it goes down. First, the muscles in the throat get all relaxed and floppy. Then, gravity just takes over, and the tongue and soft palate literally fall backward, creating a complete physical blockage. No air can get through. So what happens next? Oxygen levels tank. That's hypoxia. The brain senses this mortal danger and completely panics. It sends out an emergency alarm that jolts the person awake, gasping for air. And this awful cycle can happen hundreds of times a night, just completely wrecking any chance of restorative sleep.
Okay, so we get the science, we see the risks. What do we actually do about it? Let's open up our nursing playbook. It all really comes down to three key actions: protect, assess, and intervene.
In the hospital, you have to become a fierce protector of sleep. I'm serious. The goal is to give your patients solid, uninterrupted blocks of at least 2 to 3 hours. So the most important thing you can do is cluster your care. Don't go in one time for meds, then again for vitals, and a third time for an IV check. Do it all at once. You also need to actively push for quiet hours. Dim the lights, close doors, turn down those alarms, and use a sleep bundle. Eye masks, earplugs. These aren't just nice-to-have things. They are proven interventions that prevent ICU delirium.
Now, it's not just the environment we have to worry about. We have to be really smart about pharmacology risks, too. When you're thinking about giving benzodiazepines to older adults, the danger really comes down to one core physiological fact: their bodies metabolize these drugs way, way more slowly.
And because that drug is just hanging out in their system for so much longer, it creates this whole cascade of dangerous effects. You see this profound next-day sedation, major confusion, and a huge risk for falls. And here's a huge clinical red flag for you. If you have a patient who was previously continent and they suddenly become incontinent, you need to be thinking drug toxicity. That's a classic sign.
All right, switching gears to our littlest patients. Here, the absolute top priority is preventing sudden infant death syndrome, or SIDS. The rules are simple, they are not negotiable, and they're super easy to remember with the ABCs. A is for alone. B is for back, always, always place them supine. And C is for crib, a safety-approved crib with a nice, firm mattress.
And to be absolutely crystal clear, let's talk about what should never, ever be in that crib. No soft stuff at all. No pillows, no thick, fluffy blankets, no stuffed animals, and definitely no crib bumpers. These are all suffocation hazards, and they dramatically increase the risk of SIDS. The crib environment has to be bare, period.
All right, let's bring this all home. We're going to synthesize all this into the most critical, high-yield points that you absolutely need to know for your exams and, more importantly, for your practice. This is the stuff that gets tested, so listen up.
Okay, let's lock in these takeaways. First, sleep architecture. Simple. NREM is for physical repair, REM is for brain restoration. Got it? Obstructive sleep apnea? Your priorities are monitoring that airway post-op, avoiding the supine position, and making sure they use their CPAP. Benzodiazepines? Just think major red flag in older adults. It causes confusion, falls, and that heavy next-day sedation. And finally, SIDS prevention. It's all about back to sleep. Supine position, firm mattress, no co-sleeping, and 0 soft items in the crib.
So as we wrap this up, I'm going to leave you with a question to take into your next clinical rotation. After everything we've just covered, from the silent collapse of an airway and OSA to the subtle signs of benzie toxicity, which one of these hidden sleep risks will you make it your priority to screen for first?